so much, Sabine. And yeah, as Sabine has warned, I'm a PhD student in statistics. Um, Both me and Matt come at this from a very quantitative and mathsy angle, but really what we thought the aim of today would be to sort of bring to you a summary of how this field has been approached by statisticians and by sort of this quantitative machine learning too side. Um, so that if you have any questions or especially if you can bring any insight and from the other side, I'd be very interested to hear your thoughts. I've tried to keep this as non-technical as possible in terms of the statistics, but again, if you have any questions or if I haven't made anything too clear, then feel free to ask away. So you might have heard of this term of algorithmic fairness. It's really popped off in the last 5 years or so in the machine learning community. But before I can really talk about what this means in practice, I need to talk about what the algorithmic part of it is. And as Sabine introduced, we work in clinical prediction models. If you think about things like AI or machine learning, these are also, for the most part, clinical prediction models. So I'm briefly going to introduce what they are. So clinical prediction models are statistical models which use individual predictors of a patient in order to predict what their risk is of developing an outcome of interest. So if you think about a patient coming in, they have a set of characteristics, for example, female, 42 years old, with a family history of diabetes and who currently smokes. Those factors are going to be included or put into this model so that the model gives a prediction for that patient of, for example, the risk they're going to be hospitalized in the next 6 months, the risk that they're going to develop diabetes in the next 2 years, or the risk that they're going to die in 10 years. And an example of a model like this is QRisk. It's currently used a lot in the UK. It's a cardiovascular disease model. So what it does, it predicts the risk that a patient has of developing a heart attack or stroke in the next 10 years. And it's used a lot by people like GPs and cardiologists to know whether a patient is high risk enough that it makes sense to give them, for example, statins or antihypertensives, whether it makes sense to really drive the point forward that a patient should, for example, stop smoking or change their lifestyle in any way. So they can be really useful to guide treatment. In addition to guiding treatment, they're also very good, for example, for screening. So it doesn't make sense to make invasive biopsies in everyone. We really want to single out those patients that we think are going to really need these screening tests in order to prioritize them. They're also very good for risk communication. So people like to know what their risk is, whether it is what your odds are or making it out of a particular surgery to what your future risk of developing diabetes is. So they can, in that sense, increase the trust between patients and clinicians and the healthcare system by just giving them more information that they can actually use. And of course, they're used a lot for resource management. So if you have limited number of beds, if you have a limited number of organs that you can transplant or surgeries that you can make in a day, they are very helpful for hospitals, for example, to prioritize patients. And really, the running thread of a lot of these applications is that these models, whether they are AI or traditional statistical models, they act as gates of service. So they tell sort of health systems whether a patient should get treatment, whether they should get tests, whether they should get access to a clinical study or to a particular program, whether they should be prioritized over others, and in general, whether we should pay any attention to the patient or leave them be. And of course, it's not only about letting people in, but it's also about letting people out. So it keeps patients away from over-testing harm, for over-treatment harm, and things of the sort. So they are very useful for that, but they also, the fact that they occupy this sort of core situation in the healthcare system can mean that they can have a lot of impact in terms of health inequalities behind the scenes. And I think the best way to look at this is through an example of a situation in which this has happened. This is a study that was published in 2019 by researchers. I think they were from a California university. I do not remember which one, but it was published in Science. The researchers sought to validate a particular clinical prediction model. It was a commercial algorithm that was used in the United States by a lot of hospitals. What it did was identify high-risk patients so that they would then be referred to a preventive care program in order to receive sort of extra resources and attention in order to prevent them from developing further conditions. Their estimate of the paper was that this particular algorithm was used in around 200 million patients. So because sometimes these algorithms are commercials and tied to things like electronic health record management systems, they can really impact a lot of people at the same time. And what the researchers found was quite striking. So again, sorry for showing a graph, but what researchers found was that for the validation in a particular hospital, patients with the same risk score, which is the x-axis here, for example, a risk score is 70%. For those patients with that risk score, Black patients, which is the purple curve here, were projected to have a higher number of active chronic conditions than white patients. So they were going to be sicker than white patients. So there was some problem in calibration in the model that hadn't been detected before. And in the graph, it might look like a big difference, but it was a big difference in practice in terms of what the program looked like. So if we talk about that preventive care program, in terms of percentage of allocation between Black and white patients, and this is excluding other ethnicities or races for the purpose of simplicity, but around 20% of the program was in practice allocated to Black patients. Had the model been properly recalibrated, according to that chronic condition sort of difference that we were observing, around 50% of the program should have been made up of Black patients. So this is a very big difference. And because these things can be sneaky and they might not be noticed from day-to-day experience, they can have sort of this huge behind-the-scenes impact to health inequalities and to how much resources are sort of allocated to underserved sections of the population. So it's important to think about, and I'll try not to get too technical, but really these things can happen at a lot of stages of these models being put into practice. So usually you can split how these models are created into three parts. The data, whether we're using a clinical study, electronic health records, the modeling part, so statisticians, machine learning, data scientists, what models do we use to actually do these predictions and how do we develop them, and the deployment. And really unfairness or sort of this impact can seep into different stages, and it's going to affect the model differently. But at the end, all of these can trickle down into patient impact and really have big differences. So if I go into some examples into those three parts of the pipeline, in terms of data, underserved patients tend to be or can be minorities in the data, either because they're literal minorities and a random sampling is not going to catch a lot of them, or because of things like selection bias in clinical studies, for example. And this can affect how much the model can fit to them or learn from them. There's also data quality issues. So if you look at electronic health records, if you go to an underserved area, the quality or the amount of information that can be collected for each patient is not going to be the same. But if you're looking at a high socioeconomic status area, and there's also things like underdiagnosis and delays that are caked into the data, and that the model is going to learn from them and sort of repeat. in terms of the modeling, and this is really the decisions that statisticians make, things like choosing what outcome we're supposed to predict can have a big impact. So if we think, for example, an example where we want to predict whether someone's going to have an adverse reaction to treatment, we can rely on patient-reported outcomes to know whether a patient is having an adverse reaction. We can rely on a collection of symptoms that we think is representative of the adverse reactions that you observe, or we can go for a more serious outcome like hospitalization. And things that are very familiar to social scientists, like construct validity, are completely unheard of to statisticians, and even less so to machine learning data scientists. So really, these things are chosen without a lot of thought with what impact they're actually going to have. Same goes for the predictors, the things we use to predict whether a patient is going to have an outcome or another. And really, the balance between bias and variance is sort of a very statistics technical thing. But an analogy I could use to sort of approach it is that imagine you're developing a website. You can have a very robust, simple website that's just text on a page, but it's not going to be accessible to a lot of people. So if you don't have ability to change the font size, for example, maybe some people are not going to be able to read the text. If you don't have a colorblind mode, some people aren't going to be able to access it. You can have things like audio descriptions. As you add more and more features to your website, you also add the possibility that it's going to break because of bugs, right? And in a way, you need more beta testers to look at your website. And it's the same for models. The more you fit to edge cases with things like more machine learning, complicated models, you're going to be able to account for the fact that not everyone is the same, but you're also going to introduce the possibility that you're going to have this failing situations in which the model is going to be bad for everyone. And because of that, you need more sample size. And if you're limited by sample size, then you have to make a decision. How complicated do I want to make my model? Which is a choice that statisticians need to make, and that is going to affect patients down the line. In terms of deployment, we have to think about how these models are audited in practice. So how do we check whether the models are working the way we want them to work? If they do not work the way we want them to work, how do we update them so that in the future they do better? And then there's things related to sort of digital health equity in terms of how accessible are these models in practice, and also how are these models interpreted by different clinicians and different people. So risks and probability are sort of a very well-defined statistical idea, but in practice, they're going to be interpreted in different ways. And I don't think in general, not a lot of work, at least from our point of statistics, has been looked at how, for example, different patients culturally interpret risks and how they change their behavior according to them. So those are very interesting ideas in terms of how the deployment can affect how beneficial these models are. But really, and again, this comes from our perspective of statisticians and data scientists, but the only thing we can change is the modeling, and or we can help inform sort of how the data set should be collected and how it should be deployed in practice. But the biggest worry for us is whether we're doing modeling choices that are affecting patients. And really, the field of algorithmic fairness is all about that. How do we make modeling choices that are going to be fair or considered fair? So I'm now going to introduce this field of research. So algorithmic fairness could be defined as the absence of any prejudice or favoritism in an algorithm towards an individual or group based on their inherent or acquired characteristics. So this could be gender, ethnicity, age, socioeconomic status, and more. It has origins in machine learning. So it's not so much of a statistics field. It really started in machine learning with applications in insurance pricing, recidivism in the justice system, face recognition, hiring decisions, advertising. For all of these applications and all these fields, there's been stories like the one I've mentioned above, where a commercial algorithm that was used in a lot of people was found to be discriminatory in some way and had a big impact. So really, there's a need to find ways in which we can prevent these things from happening. what this means in practice for a lot of the algorithmic fairness world is to create models that satisfy some mathematical definition of fairness. So it's not a very sort of normative concept when it's applied in practice. It's more about mathematical definitions. So for example, demographic parity is a very popular one, which states that a model is fair if its predictions are on average the same for all group. So if white patients and black patients, the example I mentioned before, got on average the same risk score. Equalized odds states that actually it's the performance that should be the same for all groups. And there's many more ways to define this, but they all rely on this idea that the model should be in some way independent from these protected attributes. So it's a bit about blinding the model from having access to these attributes. And really in these definitions come all the challenges that come with this field and that have really made people struggle. For starters, it's actually very hard to blind models from protected attributes. There's this very interesting study that was published in the Lancet Digital Health. This group of researchers found that actually for AI models that were looking at CT scans, it was very difficult to blind them from predicting ethnicity from the data. So they actually, even with images of very low quality, like the one I'm pointing to right now, this one, which are just sort of very low quality CT scans, the AI models could very easily predict the ethnicity of a patient. And it's sort of counterintuitive in the sense that a radiologist could never, and I'm not saying that it's a biological difference, and it could be sort of thousands of correlations that the model is picking up and that is using for this. So in practice, what this means is that if we're using an AI model to predict something, it's very hard to stop it from having access to this information, which obviously can be a problem. There's also problems for statistical merges. So this is a very old example from the 70s, but Berkeley University was accused of being discriminatory in its admissions practice because an average woman had a lower admission rate than men. Upon further inspection, and what they found was that for each individual course, or for most of each individual course, women had a higher acceptance rate than men. It was just that overall, women tended to apply to courses that were harder to get in than men, which meant that if you looked at it from a bird's eye view without looking at course-specific acceptance, you found this difference. So there's a lot of situations in which it might look that a model is fair, but it's not actually if you look at another level in terms of statistics, or the opposite, where a model might look unfair, but actually if you look across another level, you're going to find that actually it was just an illusion in a way. There's some way to approach this more systematically in a way. So there's this new concept called counterfactual fairness, but the idea basically is that you create a diagram, a causal diagram of what you think is happening in your data or in your population in terms of discrimination, and also just things that affect the final outcome. So there's an example with income, but the idea here statistically is to create from this diagram an algorithm that really makes it so that if causally, for example, your sex was different, then your predicted outcome by the algorithm should be the same. And again, this depends a lot on the diagram you draw on and so the assumptions you have, but it makes them explicit, which can be useful to prevent things like previous slide. Another problem is that there's just too many definitions and no one agrees on which ones are appropriate. Here's a 2016 example in the justice system in the US again. ProPublica, which is a journalist group, published this story where they found out that the COMPAS algorithm, which was a software used to decide whether patients were likely to commit crime again and whether they should be released early or not. Not patients, sorry, individuals. And what they found was that in Black individuals, false positive errors were much more likely than false negative errors, whereas for white individuals, false negative errors were much more likely than false positive. So in other words, Black people were more likely to be predicted to commit in the future crime, whereas when they didn't actually, whereas for white patients, there was the opposite. They were more likely to be predicted not to commit crime in, say, the next 5 years after release, whereas they actually did. When this came out, this was a huge story, right? It's a model that was being used in the justice system in the US that was discriminatory. The people behind the algorithm came out with a research paper that stated that actually, if you use all the fairness definitions, the model was perfectly fair. So if, for example, you looked at the average risk score compared to the actual risk score that Black and white individuals were given, the calibration of that was correct. So really, there's a lot of opportunities for whitewashing in terms of if you want to convince to someone that a model is going to be unfair or fair or affect health inequalities or not affect them, you can just pick the definitions that are going to make your model appear a certain way, which can be a problem. And really what this comes from is from the fact that we have 10 different areas all trying to find ways in which to make their statistical models fair. But what's fair in one area isn't fair in another. So if we look at advertising, another area where a lot of this has come out, these generally a low stakes area. So it's okay if you commit mistakes into recommending someone an Amazon book. And you can really prioritize equality in predictions, for example, of performance. So you really are okay with committing more mistakes in whether people are going to buy your product or not in the name of fairness. Recidivism is a more high stakes situation in which mistakes are harder to justify. Transparency is more important, so you really need to make sure that people and the public understand why someone has gotten the decision that they have gotten. And generally, it's understood that models should be blinded against all predicted attributes, period, right? We shouldn't be using ethnicity or race or gender to predict where someone is going to commit crime in the future in order to release them or not, right? It's completely unethical. In banking, when we think about credit scores and credit loan algorithms, we also expect them to be blinded, but there's also some reasonable indirect use. So we know that things like your overall income or annual income is correlated to all sort of your socio demographic background. But it's generally viewed, at least legally, that it's okay for banks to use this information to predict whether they should give you a loan or not. So really, there's differences and nuances in all of these areas, and it's no different from healthcare. It might be because we come from the healthcare perspective, but at least I view it as a more complicated area. And this is a big problem in that a lot of data scientists, a lot of statisticians are borrowing ideas from this algorithmic fairness field and just transporting them into healthcare. And what these methods tend to do, if not in theory, definitely in practice, is to just make the performance of the model equal across all groups or cross sections of the population by leveling down. So it just makes the performance in the higher performing groups worse and doesn't really affect the performance or even makes worse the performance in underserved groups in the name of equality. And this doesn't really make too much sense for healthcare. As really, if we can agree on one thing, we want to improve people's health, especially underserved people's health. So it's really not appropriate. There's also the idea that in some way it's okay to use these protected attributes to predictions in healthcare. We think that there's genuine reasons because of genuine reason differences. So, for example, if we go back to the Q-risk algorithm, your risk, whether your ethnicity is marked as white, is going to be different whether your ethnicity is marked as Bangladeshi. It doesn't matter whether it's because of statistical variations in genetic variance in different groups, or because it's social cultural differences, or just demographic shifts. At the end of the day, these are genuine differences that are not because of bias in the data. So we probably want to model them. There's some approaches in terms of the statistics of it and how to do this based on these ideas of using causal inference. So in our diagrams, we can separate paths that we think are genuine to paths that we think are related to things like bias and discrimination, so that we can create models that are ignoring sort of the differences because of the bias and discrimination, but accepting sort of the genuine reasons. But even then, it's all about thinking about the actual use of the model. So if we look at, for example, maternal mortality rates in the United States, we know that Black women have a higher maternal mortality risk than women of other races. We think that a lot of this is just because of discrimination. They're not getting the attention they need at the time of actually needing it. And for example, we could ask the question, well, if we're developing a model to predict maternal mortality, should we use ethnicity? Well, it depends a bit on what we want to use the model for, right? So if we're using the model to decide which woman should get monitored more heavily, then perhaps it does make sense to include ethnicity. If it's whether it's because of discrimination or not, if Black women are dying more, then we should bring more attention to Black women compared to other women. So it makes sense to include ethnicity. However, if the model then goes on to be used as a benchmarking if it's useful benchmarking, for example, the performance of the maternity unit compared to other hospitals, then we don't really want to put into the model this systematic mistake that the system is making, right? So it really depends on the application of the model, on whether we want to model these things or not. There's some progress in how we should more systematically think about this. There's this a really nice perspective published in NPJ Digital Medicine by Paulus and Kent that splits decisions in healthcare between non-polar decisions and polar decisions. So non-polar decisions or predictions are decisions in which what the patient wants is the same of what the healthcare system or the clinician wants. So for example, when we're prescribing statins, usually the patient only wants statins if it's going to help them, right? And that's the same that the clinician wants. So in these situations, we really should think about potential bias in the data, but really on focusing on performance and making the performance for each group as good as possible. Whereas in polar predictions, which are predictions in which the patient and the clinician do not really want the same thing. So think about priority for organ transplants or for knee replacement surgeries. Patients usually want to have as much priority as they can, whereas clinicians have to think about how other patients fit into this and how resources are allocated. And in those situations, it makes maybe more sense to restrict our inputs or outputs. I'm going to finish the talk by just giving a brief view of some of our own work into this area and how we're trying to bring health equity into algorithmic fairness so that we can think about clinical prediction models in a better way, especially for, again, statisticians and modelers, as really the areas you should not thought about too much. So as I've gone through before, fairness is a bit of a vague concept for modelers. But I think health equity has received a lot of literature and discussion and thought in the past 30 years. And there's a lot of lessons we can get from there as starting points. And I want to highlight some ideas that I think are relevant for this discussion. And if you think I'm missing completely the point of health equity and there's actually something I'm completely overlooking, just I'd be very eager to know your thoughts later in the Q&A. But a way to define equity or health equity is that it's all about enhancing opportunities for all individuals to achieve their optimal health, right? So when we're bringing a healthcare solution, whether it's a drug or a model or anything, we want to make sure that that solution is beneficial for everyone, no matter, or in the population of interest, right? So no matter the gender, ethnicity, socioeconomic status, age, etc., etc. Ideally, this means reducing health inequalities. And I say ideally because this should come by leveling up, by improving the well-being of those at the bottom, not by leveling down, by just harming those at the top and not doing anything with those at the bottom, right? It's about health inequalities by uplifting people. And finally, and this is also important, health equity is not the only goal in healthcare. Part of the role of healthcare is just to improve and maintain the health and well-being of the overall population. And it's important to recognize when these two goals might come at odds. So our approach is to use a particular sort of metric that's now used more in clinical prediction models called the net benefit. The idea is that we think about the decision that the model is informing. If you think really about a single treat or not decision, for example, there's really four things that can happen. Either the patient needed the treatment and they got it, or they didn't, or the patient didn't need the treatment and they didn't get it, or they got it. So there's sort of this 4x4 table here of things that can happen to a patient, and some might be better or worse than others. So in some situation, a false positive could be really harmful compared to a false negative. In others, it's the opposite, right? Missing something is much more harmful than actually flagging someone as positive. So this is a very health economics-y approach to this. But from this, we can create this quantitative metric called the net benefit and create these things called decision curves, which basically explore a different range of assumptions of how harmful a false positive is compared to a false negative. But really the idea is that if a model, here is just an example of a single model validated here, is above another across the range, then we think that the model is beneficial compared to that other model. And especially, it's especially useful if we consider the default policy that is de facto being used. Is the model going to benefit patients in that context when we introduce the model and stop doing whatever we are doing before? So coming from this idea of net benefit and having a rough estimate of the benefit of a model in a population, we can think about questions about whether each group is benefited by the introduction of the model. So is anyone being harmed? That's the first thing you should check. Are gaps in benefit reduced by the introduction of this model? So are we seeing sort of health inequalities reduced, at least in this very narrow conception? And finally, is the population overall benefited by the model? So I'll quickly go through an example. This is a toy example in diabetes preventive care using UK Biobank data. The subgroup net benefit is sort of the measure here in the y-axis, and we have different ethnicities: Asian, Black, other, white, and overall. What we saw was that after introducing these different clinical prediction models, they're pink, blue, and green in this plot, all groups, all ethnicities were benefited by the introduction of this model. And especially the Asian and Black groups were particularly benefited, meaning that health inequalities were reduced in that sense. Interestingly, if you looked at lottery policies that just take, for example, 5% of people at random and put them in the program, were found to be harmful. Interestingly, they also reduced healthcare inequalities by just harming everyone, because the white group was especially harmed because of a high rate of false positives. But generally, the point is that even though the models helped people and they relieved somewhat healthcare inequalities, there's still big differences, and we can't really just rely on things like AI to fix healthcare inequalities. It's much more about intervening at all these different stages, and no model is going to fix this, right? Another interesting example is, and I'm not going to present the results, but we explore an example of lung cancer screening, also using UK Biobank data. But what we found was that the overall benefit, as we started introducing resource limitations. So what if we can only screen 1% of the population or 5%? We start seeing a trade-off appear between the overall benefit of the entire population and the benefit of the most undeserved subgroups. So we start having to make sort of normative choices of what we should prioritize. And it was interesting to see this idea appear sort of organically from the maths of it all, as it comes back to this idea in inequity that health equity is partly linked to the principle of distributive justice. When we have limited resources, how can we distribute them across the population in a way that is fair? This is just one tool in the toolbox. So really, we should be thinking about fairness and health equity at every step of model development. It's also a very rough tool. So it's not a health technology assessment. It doesn't show proof that your model is going to actually reduce health inequalities. It's just a rough estimate given the data, which is all statisticians do really. And I'm just going to finish by highlighting a couple of like further steps that I think are interesting. So one particular thing I'm focusing now on my PhD, as I'm finishing some of my previous work, is dealing with underdiagnosis. So we know from qualitative work and also from quantitative work on sort of these big data sets that there's underdiagnosis in the data, right? Or in the system. For example, if we look at breast cancer, Black women again have a higher number of delays and are caught at later stages compared to white women in the UK. Now the question is, how should statisticians use this information? So we're working on methods to take, for example, this information of staging or underdiagnosis and putting it back into these models using causal inferences approaches, so that we can correct for the fact that we know that the data is not fully representative of the reality of the situation. Another interesting step is knowing who we should sample. So this is a picture from the Manchester Lung Health Check program where CT scans are sort of brought to deprived areas in order to try to catch lung cancer cases earlier. Clinical prediction models are used to detect who is likely to have lung cancer or who should get a CT scan. We don't know whether these models, or we only have some evidence for now that these models are as good as they could be in the UK population and in underserved UK populations. But because we're not sampling everyone, we're really only testing whether lung cancer is present in part of the population. We could ask the question, should we make more CT scans than recommended by the model in some populations because we think that we're actually very uncertain in terms of the model performance in that population? So that is a statistical problem that we're also trying to look at that is very interesting. And really at the end of the day, I think what's really going to help this field is bringing everyone together. So I think there's definitions of fairness that make sense to decision makers, to patients, to social scientists, to statisticians, clinicians, machine learning engineers, and the public. They're not always the same. And I think the increased discussion of what fairness means for things like AI systems and clinical prediction models would really benefit in creating a more cohesive view in which everyone is testing and trying to go for the same thing. So here are some references. If you're interested, I can provide the slides if anyone wants them. And thank you all. And we're open to any questions or, again, thoughts.